Good evening, everyone. It's a pleasure and honor to have you all. We have the esteemed faculties today for the session. I would like to invite Dr. Girish Bashaw, Dr. Nikul Panchal, Dr. Devendra Sharma, Dr. Rohit Mathur, Dr. Amol Agrawal, and Dr. Shibashish Sahu as the respected moderators and chair. Over to chair to introduce our speakers, the case, and then invite the speakers for the debate. Over to chairpersons.
Thank you. Thank you, dear. So I am Dr. Rohit Mathur, and it's always been an honor and privilege to be a part of Cardicon. And today the session is about ISR, and let me have the pleasure to invite Dr. Frank Kleber. He's a medical director at Paul Gerhardt Stift, Germany, and head physician in the Department of Cardiology. He is an interventional and conservative cardiologist, and he has been there for almost from June 2017 to June 2018. He has his expertise in clinical and experimental heart failure and interventional cardiology involving both coronary and extracoronary structural heart disease. And he has got many publications with his credit. Let me not waste any time and invite Dr. Frank. Dr. Frank, you are on the screen now.
Thank you very much for this kind invitation, for the kind introduction, and we'll take the next 10 minutes to talk about drug-coated balloons for a special case with instant restenosis with a non-treated diagonal branch, if I understand this correctly, and a stent in the LAD overlapping this diagonal branch. So what are the options with drug-coated balloons? Well, first of all, I'd like to mention that for treatment of instant restenosis, according to the European Society of Cardiology guidelines, and proven by a really huge number of studies, randomized trials, the drug-coated balloon technology is the technology of choice. First of all, because it's at least as good as a stent, and it does not bring additional material into the coronary tree. The basic benefit of drug-coated balloons in any situation is the mimicry of the Glago effect, which means that the vessel gets larger and can tolerate a higher burden of plug material. And then this physiologic mechanism during the development of atherosclerosis is basically induced in this setting by the drug, which is mostly, as you know, paclitaxel. This has also been shown if you apply paclitaxel in animal experiments to the pericardium, you even, in this situation, you have to increase in vessel size, which you see here measured as the external elastic membrane area. Now, years ago, we were the first to describe this in de novo coronary disease, and we saw a rightward shift of the MLD diameters over the range of various diameters in a small to moderate size group of patients. So almost the big majority of patients after DCB application has a larger vessel 4 to 6 months after the initial PCI. This has been repeated by several groups with several technologies. Here, interestingly, it is the Korean group, and they showed when you have your early result of PCI here that not only the main vessel dilates, but also the side branch ostium. Of course, if you increase the size of the whole vessel, of course, the side branch ostium must increase, and this has been shown by OCT very nicely by Dr. Shin and colleagues here. Dr. Hare is the first author of this publication. We also did the first a randomized trial in bifurcations with drug-coated balloons. And as you see here, we were able to show, as compared to a regular balloon, the binary restenosis for the side branch goes down from 26 to 6% with DCB. So very good for side branches. This is not ISR so far. And also important, as you know, DCBs have a lower rate of thrombotic occlusion of the artery, as has been shown by the SCAR registry. So another advantage for this. Now, in terms of our case, of course, this is a very special situation, and we don't have so many data on exactly this situation. But we have, in terms of bifurcation lesions, a very nice meta-analysis by Simon Ecclestone's group. And I show you, this is the amount of publications they put together, 688 lesions, predominantly LADD1 lesions. And in 281 lesions, they were just looking at main stent, main vessel stenting, and side branch with drug-coated balloon or not drug-coated balloon with various comparators. And this is basically these three studies which give you some information on this. Especially important, the study by Herrador, because he used a DS in the main branch and compared this to the regular treatment. And as you see here, overall, these studies showed a quite clear benefit for the DCB versus POBA for the side branch when you stent the main branch. But the question is, of course, whether you have to stent the main branch. But this is not our case today. And there's another interesting analysis by Dr. Zheng from Nanjing in China. And he looked also into several studies. And as you see here, the MLD of the side branch is better with the DCB treatment. The same is true for the diameter stenosis. The same is true for late lumen loss, better with the DCB for the side branch, and here for the binary restenosis rate. Overall, they looked also into endpoints, and for the combined endpoint of major adverse cardiac events, there was, by the time you see here from 1 month to 12 months, a increasing benefit for the DCB as compared to non-DCB treatment of a side branch. Another study looked at the impact of late lumen loss on clinical outcomes in side branch bifurcation lesions, published by Ikuta from Japan. And these authors concluded that 71% of the patients in this series had late luminal gain, as I showed you in de novo as well. And the side branch late luminal gain was associated with less target lesion revascularization and less MACE. So I think for the side branches, there is little doubt that the treatment with drug-coated balloons is the recommended treatment. This also goes along with the Asian Pacific recommendation, which says, therefore, it is recommended that DES-ISR lesions be treated with DCB if the angiographic results are good after balloon angioplasty, and if otherwise, they should be treated with newer generation DES. Most important, when you treat a side branch lesion or any lesion with a DCB, is to nicely predilate the lesion and to reach the lesion within a short time. Our attitude is to reach the lesion in most cases within 30 seconds. In some, we need 60 seconds, but almost all lesions are done within 1 minute, because you lose the drug if you don't take care that from insertion to the guide catheter to expansion of the balloon in the lesion, it should not be more than a minute. In our hands, we mostly treat de novo lesions. But in a untreated side branch, as is the case here in this case, I think the physiology is not so different that we could not apply the drug-coated balloon with mostly paclitaxel, currently at least, for the best benefit of the patient. I think this is about what we currently know about this situation. Of course, I have not seen the angiographic pictures. It might be useful to see whether this is also has to do with some amount of restenosis in the main branch, which of course would have to be treated before. But depending on the good result of the side branch predilatation, in our hands, this would be the preferred treatment. Thank you very much.
So, thank you, Dr. Franz, for your exciting enlightenment on the use of paclitaxel eluting balloons. Dr. Amol?
Yes.
Yeah, Dr. Amol, can we invite the next one, please?
Yeah, so I have the pleasure of inviting Dr. Jayesh Prajapati, who will be presenting the counter argument whether drug-eluting stent will be better, especially thin stent in such a case if atherosclerosis is found. So to introduce Dr. Jayesh Prajapati, he is working as professor and head of the Department of Cardiology at UN Mehta Institute of Cardiology, Ahmedabad, also working as director cath lab and senior cardiologist at Apollo Hospital. And he has a vast experience in complex angioplasty and in various other high-end interventions. He has been invited as faculty for national international conferences like CAD, AICT, and EuroPCR, TCT, Asia Pacific, presented various papers at national and international forum, and is a principal investigator in PCHF and F biometric registry. So may I invite Dr. Jayesh Bhai for his talk.
Good evening, dear friends or chairperson, co-chairperson, and of course the speakers. First of all, I'd like to congratulate Dr. Kamal for organizing such a wonderful CME with variety of topics. So just I share my screen. So of course, this is it's a unique case Kamal has posted that patient already been implanted 3 years back, DES has been implanted. So stent is patent and there is a diagonal which is large and it is in ACS situation, 99% occluded. So of course, what is that? So it's of course, it's a non-true bifurcation. I can say it's a Medina 001. And when it is a non-left-made bifurcation, it is very difficult. Even with a left main or only circumflex ostium, it is also dilemma how to go ahead. And this is a non-left main bifurcation and Medina 001. So there are so many issues. Even with a most of the times say that diagonal is not an ACS situation. We have to see how much area is supplied. If the area is not significant, so of course we have to try the medical management. And then of course the option is, suppose we want to treat it, area supply is large, patient symptomatic. And this is ACS situation, large diagonal, of course need to be treated. So how we can treat it? So there are options available. Of course, so today's discussion is DEB versus stenting or something other thing. So osteal lesions, at least we should profile and then either we can use a lesion preparation is a must because ostium is a different thing. It's a recoil with a balloon only. So we have to profile the lesion, then we have to prepare the lesion, and then we have to either do a DEB or the DES implantation. Issue is that when you do a DEB, there are 15% chances that you land minimal human area is less, or you develop with a dissection or recoil of the lesion, and then ultimately you have to implant a stent. So why not to go with a DES implantation straight away? There are no clear-cut guidelines, which is the better one, and there are not much studies available for non-left main bifurcation Medina 001. And of course, there are DEB, there are certain issues, which drug, how it is coated, which company, what is the carrier material, and we require large, there is no head-to-head comparison, large data available in Medina 001 non-left main. So of course, and there are certain issues, of course, related with the stent also. So stent, sometime what happened, except it is a very 90-degree angle, you can implant a stent perfectly. Otherwise, there will be either a geographical miss. So there are certain techniques where you can safely implant a stent. So there are no randomized data. So one thing is that we requires intravascular imaging to see for the lesion mode, because it's a new atherosclerosis. It is not a true bifurcation, as my first speaker has rightly mentioned. This was not a true bifurcation lesion. And of course, we know that the indication for the DEB is class 1 is only with ISR if you don't want to go with a much metal. So one, we have to profile the reason, and of course, we have to see the physiological assessment. But here also it's a 99% lesion, patient is symptomatic. So anyway, we have to treat because the ACS situation and there is an angina. So before treating just kind, we have to be sure that it's a necessary for the patient. So everything is important: lesion morphology, territory, clinical scenario, and everything. So these are some of the small studies are there, and say the diagonal even up to 2 mm, 2.25, you can leave it. But here we need to treat it. When I gone through all this drug-eluting balloon data, of course the numbers are not that huge, but all this study and all this meta-analysis says that the TLR was similar both with the DES and DCB. Both were better than the plain balloon angioplasty, and Reeves 4 has done the DES better. But of course, there are when we don't want to put more metal or the DAPT an issue, then of course the DES or BMS restenosis, DEB also one of the good, or I can say equivalent option compared to the DEB. For other, it is a debatable one. So when we see the guideline, there are not much updated guideline available, but even the 2014 guidelines say that the drug-coated balloon are equivalent to the DES class 1A indication, particularly when it is a ISR only, that we should keep in mind. When we see the DNO, of course, already this trial has been discussed by my previous speaker. So when the meta-analysis versus DEB was for de novo lesion, even with a large vessel or the small vessel, the conclusion that DEB are not superior to the current standard therapies, either DES in treating the de novo lesion, and DEB efficacy seems to lie between the DES and BMS with a trend towards superiority over BMS alone. So if we are able to implant a DES in a good manner, then of course it is a better strategy compared to the drug-eluting balloon. So issue is that how we can implant this drug-eluting stents. So of course we have to profile the lesion with imaging technology, and we have to see, then we have to prepare the lesion correctly, either with a scoring balloon, cutting balloon, or whatsoever, and then we can use a various technique, like you can put a flush stenting, or we can put a balloon crust, or we can do a provisional stenting. So just we put a stent into the side branch to the main branch, and then we recross and we open the side branch, and then we can implant either a drug-eluting balloon in the main vessel and branch vessel, just you put a stent. So that is the one strategy you can do, or shoulder technique, like crush with a balloon and then complete the procedure with a drug-eluting balloon. So you all the diagonal, so cover diagonal origin and everything will be covered by a good drug-eluting stent. And there are Jabot technique, some of these kind of shoulder technique, this is available. And of course, there are some of the stents will be available, the dedicated bifurcation 001 stent. So that can change the future. So of course, if we can implant a DES in a better manner, it can be better compared to a drug-eluting balloon. And of course, when we consider in a diagonal treating, we have to see how much important to treat this vessel. So in a stable angina, if we can manage medically, it is better rather to chase a diagonal. But in a ACS situation, large diagonal, we can treat with a proper manner with a DES. Then of course, a DEB also one of the option. And of course, as I have told that with DEB also, there are issues like recoil. Of course, we don't know which drug, which balloon, or which company balloon, what is the technology, everything matters while using a DEB. While with the DES, we know we are very familiar with the DES, and long-term data with DES is always better. And when we see the cost-wise, particularly country like India, where the DES very cheap compared to a drug-eluting balloon, rather here drug-eluting balloon are costlier compared to the DES. So that is also we have to keep in mind. So my take home is that drug-eluting balloon, of course, is a good thing for the DES or a BMS-induced ISR, or when we want a short-term DAPT, this is also one of the good option. And there is promising data for additional indication have been reported in the treatment of de novo lesion, side branches in the bifurcation lesion in small vessel. However, data for this indication are limited to few small randomized trials and registries. Larger randomized trials versus newer generation DES using the clinical rather than surrogate angiographic outcome are warranted. All DEBs are not equal. Different manufacturing, drug release kinetic, need for head-to-head comparison for a more appropriate disease. And of course, this technology is very old, but still there are every time we are discussing regarding the DEB. While the DES implant is a preferred strategy as a first choice, if we implant it properly rather than bail out once we develop a dissection or the recurl, if we implant with a good technique, and of course it's cost effective also. So DES also is not a bad choice. Thank you.
Yeah, thank you, Jayesh bhai, for your very nice counter argument about implanting a DES vis-a-vis a drug-eluting balloon. Now we'll invite the to invite Samir for his talk, third talk, and it will be on sirolimus eluting drug-eluting balloon with nanoparticle technology. Dr. Dani is practicing for about 20 years as 24, been professor and head at the Institute of Cardiology and Research Center. Since 2007, working as director, Department of Cardiology at Apollo Hospitals, Ahmedabad, visiting fellow in interventional cardiology at CHU Hospital, Charles Nicolle, 1995, Rouen, France. Accreditation is an ex-honorary cardiologist to His Excellency the Governor of Gujarat. He has had many research articles and many publications. May I invite Dr. Samir Dani sir for his talk.
Thank you, chairpersons, for a kind introduction. Thank you, Kamal, for inviting me here. We have had very nice talks by Professor Kleber and Professor Jayesh Prajapati. Let me share my screen. Is it visible?
Yes.
Am I audible and is the screen visible?
Yeah.
Yeah. Okay. So as Dr. Jayesh has already said, it's Medina 001, and Professor Kleber has put forward his arguments very clearly and very emphatically. And he has worked a lot in DCB area, and he is one of the authorities to talk about when to use or where to use DCB. So the issues here are whether we are going to use DCB or DES, and imaging techniques are must, or can they help us in deciding whether to use DCB or DES? And if we are going to use DCB, which I believe we should, then whether we will use a sirolimus coated balloon or a paclitaxel coated balloon. And then there are some technique related issues which are, kind of better answered by experts. There is no definite consensus whether you should do kissing balloon inflation or not, and whether you should do pot or repot or not. Well, for arguments for drug coated balloon is very well put forward, and they're very clear as per Professor Kleber's lecture. No metal layers, policy or the philosophy of leaving nothing behind. There is reduced need for prolonged dual antiplatelet therapy. The whole procedure is very repeatable. There is reduced vascular inflammatory response because of polymer-free design. And this is all very important when we are doing PCI, and drug-coated balloon gives us advantage of all this. And that's why recommendations to use DCB is there in through most of the society's guidelines, and you can see that use of DCB in the treatment of bifurcation is recommended by almost all the consensus group. German, Italian, Chinese, and European, of which Professor Kleber also is part. So I would prefer DES in very small situations in this kind of scenario where there is a large side branch. But again, now we have enough data to say that even in large side branches, DCB is almost as good as DES or non-inferior. If you do not have DCB, then it's understandable that you can use DES. Then I would, if there is suboptimal result of predilatation, maybe yes, then in that case, you could go for DES. But most of the time, if you persist if you use cutting balloon or scoring balloon or rotablator or whatever it requires to give you proper pre-dilatation, then DCB is possible, unless there is vessel occluding or flow limiting dissection. And sometimes when reducing the possibility of recurrence is the most important clinical concern, like you have a recurrent re-stenosis, that kind of situation, and then you want to put a DES and put an end to it. But otherwise, in almost all other conditions, as far as side branch is concerned, you want to avoid multiple layers. You want to, especially if you have high bleeding risk, and this like this first intervention in the side branch, an excellent result with pre-dilatation if you get, then I would prefer DCB. This is the list of commercially available DCBs. Out of that, Sequent, Please, Pantera Lux, and Impact are the only paclitaxel eluting balloons available in India. And we have Magic Touch, which is sirolimus eluting balloon, which is available in India. So we have, as far as I am aware, we have only 4 balloons available in our lab. And why sirolimus? Once we have established that drug-coated balloon is the right way to go, why sirolimus? Sirolimus has a lot of advantages, which we know, and that's why we have shifted in the stents also to limus eluting stents. The problem with sirolimus is that the tissue absorption is slow, tissue retention is short, and it is very difficult to coat sirolimus on a balloon and retain it and deliver it to the tissue. And that is why almost all the companies, when they started with paclitaxel. Of course, the difference between sirolimus and paclitaxel, you know very well. Sirolimus has a, I would say, that very wide therapeutic window, and that is why it has become kind of drug of choice. Now, this company has an nanolute technology where it creates microparticles of sirolimus, and they are coated in, encapsulated in phospholipid, which is an excipient, and then that is coated on the balloon. It has certain theoretical advantages, that it has better adhesion on the balloon surface, it is circumferential coating, drug delivery is pretty good, it has very efficient particle diffusion. Now, all this is okay, and if this is the drug dose, 1.27 microgram per square millimeter, which is much lower. Crossing profile is better because of the low drug dose, and the excipient is also less. The whole blood concentration, the PK studies are good. Sirolimus concentration in tissue is, one can demonstrate, was demonstrated in adventitia up to day 14. And these are the product specifications which is available with us here. But as we say, the proof of pudding is in eating it. So theoretically, sirolimus coated balloon may be better, but is there data? And there we are on little shaky ground, that we have a lot of clinical trials ongoing, but there is no head-to-head comparison with PCB. But at the same time, I can tell you that from my personal experience of more than 600 patients now, and we have enough amount of registries, though they are not randomized clinical trials, Nanolute SIMS, Brazil ISR, FASICO, Eastbourne registry, which is has completed more than 2,000 patients in Europe only, the Selfie registry, the UK sirolimus eluting balloon registry, which is ongoing, Transform, done by Bernardo Cortes and Patrick Saruz. PI is Antonio Colombo, who has already enrolled 74 patients. Transform 2 is enrollment has started. Picoleto 3, 400 patients, enrollment has started. The Magical registry is for US FDA proposed, and the Magical RCT also is proposed and is about to start. So in all, very robust clinical program. In our personal experience, it has demonstrated promising rates of MACE up to 3 years. The MACE rates are up to 3 years are roughly less than 7%, 6.7%. In complex cohorts also at 3 years, the MACE rates are acceptable in ISR, DES ISR, and even in small vessel. And of course, Professor Kleber alluded to the technique. It is very important when you are using drug-coated balloon to prepare the lesion optimally. And if you have suboptimal angiographic result, then only you go for DES. So in this particular case, my steps would be IVUS or FFR, vessel sizing, pre-dilatation with appropriately sized balloon, plaque modification if necessary. We would prefer cutting balloon, DCB inside branch, and then you may think of doing a kissing balloon inflation or a pod depending on your IVUS results, and then do final imaging. These are just illustrative cases. I'm not going to dwell into that. It is possible to get good angiographic results with DCB if you are meticulous. So in my experience, DES is preferred. Just to go through it again, if DCB is unavailable, or if there is re-stenosis or a lot of recurrence, or when reducing the possibility of recurrence is most important clinical concern. But otherwise, in cases like this, I would go with DCB, avoiding multiple layers and reducing the bleeding risk. And out of DCB, at present, my preference is changing to sirolimus coated balloons. Thank you.
Thank you, Dr. Samir. Thank you, Dr. Kleber and Dr. Jayesh as well. So we had an exciting discussion about all the possible therapeutic options we have for such kind of cases. So as just to summarize the things, I would say that first of all, because of this is an acute coronary syndrome presentation, so we are bound to do and not to leave patients on medical management, as we have already been told that this was a sizable diagonal. What I would like to see is also the results of the stenting procedure done for LAD, if it is available at all, of course. And that will also tell us that how exactly the diagonal behaved at the time of stenting, you know. Otherwise, as all we have discussed, that we need to go for, say, wiring, and then, of course, visualization with IVUS or OCT is very important, as so as to understand that what is the problem, why this restenosis has occurred, because this is going to play a major role in deciding the treatment strategy, whether there is a stent strut which has come across the ostia, or it is a neoatherosclerosis over which a thrombus has formed. Because this is a 001 Medina, we can always go for probably a smaller size, longer balloon to do a pre-dilatation at some lower pressure, and just see if this gets a TIMI3 flow. If the patient can stay stable, there is no dissection. Otherwise, we have options of doing stenting. If your angle is close to 90 degree, take a tap or maybe T-stenting, do a final kissing, and DAB, the role of DAB has very well been explained by Dr. Kleber and Dr. Samir Dani. Over to you, Dr. Amol, Dr. Shivashish, and other co-chairmen.
Yeah, I agree with you, Dr. Rohit. We have this wonderful option of drug-eluting balloon, where we want to reduce the metal burden, and the role of antiplatelets also will play a role in the long run, because the need of antiplatelets post DCB is by recommendation 3 months dual antiplatelet. So definitely from a case-to-case basis, the decisions can be taken. And I would like to congratulate all the 3 speakers for giving wonderful insight into this very interesting topic.
Yes, all these are DCB or DES, they're potent to only de novo lesions while we are treating that. But we are dealing a case where there is already one stent put 3 years back in the main vessel. While you do use like drug-coated balloon without kissing balloon inflation, in bench testing, it has been shown there is stent deformation in the main vessel. So yes, you have to correct that. You see, also imaging, we have also seen if you do just kissing of side branch, you will have you will have deformation of the stent. You have that also. You have to injure the main vessel.
So you mean to say, Dr. Sahu, you want to say that when you do the diagonal, finally you have to the geometry should be either do a final kissing balloon.
Final kissing balloon.
Yeah. So with DEB,
My question to all of you, I would like to change the setting slightly. Now we have high sensitivity troponins. This case, if we are just mentioning a troponin positive, does it always mean it's an acute coronary syndrome? Would it not being amounting an ACS with a large vessel, which is a side branch, still would end up getting a PCI? That's something that I want to ask each one of you. Professor Kleber, and then Dr. Jayesh Prajapati, and then Dr. Dani.
Well, for a large diagonal branch, independent whether ACS or not ACS, if the patient is symptomatic, I think we should treat this patient. In our case, we have the stent in the main vessel already done 3 years ago, and it's our attitude not to do a kissing in this situation because we think that the stent is embedded. If it's early after stenting, yes, I would do a kissing balloon dilatation with a normal balloon in the main vessel and a drug-coated balloon in the side branch. But let me say one word about sirolimus versus paclitaxel. I think this is a very interesting development currently. What we know so far is that probably the sirolimus balloon for in-stent restenosis is as good as the paclitaxel. And we have some confidence in sirolimus because we have this history of stents. For de novo, we just finished a randomized trial in Germany with the last patient in 2 days ago, and we'll see the result. My feeling is that paclitaxel causes probably or potentially more positive remodeling because it's a cytotoxic drug, while sirolimus is not cytotoxic. And that's what we see with the paclitaxel stents, that we have a lot of secondary stent malalignment caused by this positive remodeling behind the stent. You don't like this with stenting, but you like it in de novo. And you would also like it in this situation. Thank you so much.
Thanks, Dr. Kleber, for your comments. I want regarding the treatment of the diagonal. Yes, Dr. Kleber told rightly that if the diagonal, because patient was asymptomatic 3 years, he becomes symptomatic right now. And if the what I consider that if the diagonal are more than 2.25 or 2.5, and there is no bigger diagonal after this one in that LAD territory, and this diagonal is very important, we have to treat. So size of the vessel, length, and distal to that diagonal, if there are major diagonal is there or not. And of course, that also makes a difference apart from the biomarkers. And of course, for the treatment, just I want to add on that why not kissing balloon in a DEB in a main vessel also when we finish the job. Suppose I implanted a DES into the side branch diagonal and I finished correction with main vessel with a DEB.
Professor Kleber, you want to answer that, or shall I go ahead with?
Well, very briefly, I think the data by Dr. Shin shows nicely that the side branch osteum has a benefit from treating the main branch with the DEB. So it's our current attitude to use two drug-coated balloons, and in most of the certainly not in all, but in most of the bifurcation lesions, we end up without a stent.
Yes. So I think coming back to Dr. Kamal's question, if this is a large diagonal subtending to a large area of myocardium, it is wiser to do PCI. But if you want, you can do an FFR. And there have been studies where they have shown that in spite of significant angiographic stenosis, FFR of that side branch is normal sometimes, and in those cases you can leave them alone. So this is possible. If you want to do FFR, you can do that and then think about it. But certainly, if 3 years back this vessel was not stenosed and now it has become stenosed, the FFR is likely to be positive rather than negative. And another thing is that when you talk about why not final kissing or kissing balloon inflation in all the cases, couple of reasons for that. If you have a strut crossing the side branch ostium and you have to dilate at very high pressure, then you may alter the stent geometry a little bit. But otherwise, since this is a 3-year-old stent, it is unlikely that geometry will be altered that much. And we also know that when you dilate with only a balloon, the coronal shift is less likely to happen compared to dilating with a stent. So when you are doing balloon dilatation, you are less likely to create a problem there unless the stent is freshly implanted. So freshly implanted stent, absolutely yes. In less than 6-month-old stent, absolutely yes. But 3-year-old stent, I would go with IVUS. If you have a default strategy of 2 SCB or 2 DCB in your lab, it's okay. You spend more, but you are not harming.
So I have one reservation. Why would you like to do FFR in acute coronary syndrome? I mean, would you take the results of FFR in acute coronary syndrome?
Yeah. Well, no. Dr. Kamal rephrased it. He said that if this is not an ACS.
Yeah, I meant it's then
only medical management
components which can be there in patients when you're using now high sensitivity. So when you use high sensitivity, they may actually be reflector of a chronic coronary syndrome. You have a lot of patients. High sensitivity was primarily defined for chronic coronary syndromes, picking up patients who are at risk of developing event in future. So that's my perspective. So what Dr. Dani is saying is correct. So I mean, that's what sir is trying to answer. So in which case, I think imaging an FFR would be a good strategy if you think it's part of a false positive. And that's why probably in some other setups using not the high sensitivity troponin, when you're actually dealing with a definitive ACS, might be a better strategy. Again, debatable. You have different cutoffs for the both. But I think in high sensitivity in the casualty settings, to define with the cutoffs on the nanograms of 19 and 49 to diagnose an ACS is sometimes a higher false positivity rate, as we know from the literature, as compared to the not so high sensitivity, which actually give more true positive values as compared to false positives with high sensitivity.
I can show you a small anecdotal case if the time permits. A case where I put a stent in the main vessel, left alone the diagonal, which was 80%, and I thought that it was big, but it was not so big, and it would do. You know, I didn't want to disturb the left LED stent geometry. And I thought that he would do well on medical management. He did so for a couple of years, and then he came back with some kind of chest pain. And his troponin was negative. But he was very anxious that probably that diagonal is causing him angina, though that angina didn't look like a typical angina. So I did his angio again, and his diagonal was, instead of 80, it was looking like 90. But I was not sure that that was giving him angina because the symptom was atypical. So I did his FFR there. And to my surprise, FFR was like 0.9. So I left him alone, reassured him, and he's doing well. So such kind of situation may happen. And then you may think of it.
So can we have final comments, paclitaxel versus sirolimus? Professor Kleber?
I think most of important points have been mentioned. I think this was a very good discussion on this topic. It's a peculiar case. I think we learn from each other, and we have to watch the field in terms of sirolimus to see whether sirolimus is indeed better for instant restenosis.
Dr. Dani?
Yeah, I totally agree with Professor Kleber.
Is there any is there any head-to-head comparison between these two balloon strategies?
Yes, we just finished the study, but we have no results so far. Yeah, but we just finished. Last patient in 2 days ago.
Okay, so result will be published.
It was under the lead of Bruno Scherler. We both did most of the recruitments, but there were other centers involved as well. And so we'll hope to see in a year or so, we hope to see the results.
Yeah, great.
We're eagerly waiting for the results, Dr. Kleber. right? With this, I think, Dr. Kamal, we come to the end of this very exciting first session. I congratulate once again to the team of Cardicon 2022 for, what is said is that a good begin is halfway done. So I congratulate you once again, and I thanks all my speakers, co-chairpersons and chairpersons, and all the audience for joining us. Thank you.